Welcome everybody to the 6th Annual Patient Education Day. I'd like to thank you all for joining us again. I especially like to thank Bethany Schreiber for helping to organize this every year. She's done a great job of making sure that we've had excellent programs. Even during COVID, when we can't meet in person, we've fortunately been able to do virtual teaching like this. I've been invited to give a talk today about MS, NMO, and MOG. Most of you, I'm sure, have heard of MS. Many of you might have heard of NMO, and I imagine most of you have not heard of MOG. Even if you have, you probably don't know much about it. So I'm hoping by the end of today's talk, you'll have a better idea of what these three different diseases are. My goal today is to review the definitions of NMO, MS, and MOG, and try to highlight through some different cases the differences between these three diseases. Initially, we used to group all these patients together under the rubric of multiple sclerosis, but we now understand it's really important to differentiate which patients have which disease, as they have different prognosis and treatment options. And we'll discuss a little bit about those different treatment options toward the end of the talk. Multiple sclerosis, I'm sure you're all aware, is an autoimmune disease that affects the central nervous system. The central nervous system is made up of the optic nerve, the brain, and the spinal cord. And MS typically causes symptoms through relapses. So for example, optic neuritis, where you could have painful vision loss that might last a few days or weeks. And disability, unfortunately, may accrue over time due to neurodegeneration. And this can happen even independent of relapses, as patients have the disease over long periods of time. In multiple sclerosis, we know the immune system is targeting myelin, which is the protective coating that is wrapped around the axons, or the nerves, the main cells in the central nervous system. As the immune system attacks and damages the myelin, the nerves or the axons also become damaged, and that's when the symptoms arise, depending on where the inflammation is. So as I alluded to, if the optic nerve is being damaged by the immune system and the myelin is lost around the optic nerve, patients can get eye pain and vision loss. So let's look at a patient who has optic neuritis due to MS. This is a 38-year-old female, and she started having blurry vision and pain on eye movement about 3 to 4 days ago in her left eye. About 1 year ago, she noticed some tingling in her left hand, and she thought it might be related to carpal tunnel syndrome, but she never actually sought treatment about it because those symptoms went away. So she came to me, and on her exam, her visual acuity in the right eye was normal, 20/20, and in the left eye was diminished at 20/80. Her visual fields were normal in the right eye, but she clearly had some vision loss in her visual field in the left eye, and she had color vision loss in the left eye also, which is a key feature of optic neuritis. And when I did an exam shining a bright light in her eyes, there was something called an afferent pupillary defect in the left eye. That's a sign that when we see it on exam, points to damage in the optic nerve. The rest of her neurologic exam was normal. So this is a slide that highlights what an afferent pupillary defect looks like. On the top part of this slide, there is a light being shined in the right eye. You can see both pupils are constricting. When the light gets shown over to the left eye, you can see the pupils dilate. And again, this is a sign that there's damage to the optic nerve. And in a young patient like this, it's very commonly due to optic neuritis from MS. Here's our visual field test. On the right side, you can see a normal visual field, and I'm sure you can all appreciate the vision loss on the left side in the darkened area of our visual field. And so I ordered an MRI of the brain and orbits, the orbits being the eyes. And what we can see here on this MRI is a normal optic nerve on the right here. And on the left, there's inflammation in the optic nerve. This inflammation is being seen when the contrast leaks into the optic nerve. The contrast is given through an IV, which I'm sure many in the audience have had before. This patient's MRI also showed multiple lesions consistent with multiple sclerosis. If you haven't seen an MRI before, the top two MRIs are what we call T2 sequences, and the bottom two sequences are the contrast-enhancing lesions. Normally, the contrast should not leak into the brain, so when we see this, we know there's active inflammation from the multiple sclerosis. And the shape, size, and location of these lesions are highly suggestive of multiple sclerosis. 8 weeks later, she did not have any treatment. Her vision spontaneously improved. Her eye pain was gone, and she was seeing 20/20 again. And as you can note on the visual field test, her visual field returned to normal. Her color vision also returned back to normal. This is typically what happens to most patients who have optic neuritis due to multiple sclerosis. Even without treatment with steroids, they have a good prognosis for full recovery or near full recovery. Sometimes the vision is not quite 100% back to normal, but it usually gets pretty close. Sometimes patients do get steroids to hasten the recovery of their vision loss. We did blood work to look for those other diseases I mentioned. NMO, we checked for the aquaporin 4 antibody. We'll talk more about that later. We also checked for the MOG antibody, and they were both negative in her blood work. She also had a spinal tap, and her spinal tap showed illegal clonal bands, again confirming that she has multiple sclerosis. And lastly, we did an OCT scan, which stands for optical coherence tomography. If any of you have been to an ophthalmologist or an ophthalmologist's office, you might have had this test done where we take pictures of the back of the eye and we can actually measure down to the micron level the thickness of the retina around the optic nerve. Anybody who's had optic nerve damage will show thinning eventually over time in the retinal nerve fiber layer on this machine. So we can see here she had normal thickness in the right eye, 98 microns, but she lost about 10 microns in the left eye. She was then started on a medication for treating her MS and got much better. So in summary, MS can cause relapses such as optic neuritis, and early on, patients with MS frequently will recover from their relapses, whether they're treated with or without steroids. And optic neuritis in MS generally has a favorable prognosis with good recovery of vision. Now let's look at another disease, NMO or NMOSD, also used to be known as Devick's disease. This too is an autoimmune disease affecting the central nervous system, which again is the optic nerve, the brain, and the spinal cord. This can cause symptoms through relapses, for example, optic neuritis, and disability. However, the disability accrues because of the relapses, and unfortunately with NMO, the relapses can cause permanent disability, and the recovery might not be good. Even with treatment with steroids, some patients end up with permanent vision loss, or other symptoms, which we'll discuss later. The immune system in NMO targets a protein in the central nervous system called aquaporin 4. Hence, when we look for NMO disease, we check the blood for the aquaporin 4 antibody, which is a marker of the disease. The aquaporin 4 binds to astrocytes, which are one of the major important cells in the central nervous system that help support brain health. As the astrocytes get damaged, other cells in this brain or optic nerve or spinal cord also get damaged, leading to demyelination and axonal loss and permanent disability in some cases. In optic neuritis and NMO, the immune system is attacking the astrocytes in the optic nerve, and that can lead to severe permanent vision loss. So here's a case of a female, very similar, 38 years old, with blurred vision and pain in the left eye, just like our last patient. Came on over 3 to 4 days. Pain was worse with eye movement, just like our patient with MS. She also had some tingling, which she attributed to carpal tunnel a year ago. But interestingly, she also had this episode a year ago where she had intractable nausea, vomiting, and hiccups that went on for several weeks. She was hospitalized and the doctors couldn't figure out what was causing it. She had a colonoscopy, a CAT scan, they had blood work done, but they couldn't figure out if it was an infection, but they ruled out that she didn't have any inflammatory bowel disease or any other infections. The symptoms got better on their own, and she kind of forgot about it until I asked her about it. On exam, she had 20/20 vision in the right eye. Her vision loss, though, in the left eye was much more severe. She was down to count fingers vision, meaning she couldn't even see the big E on the eye chart across the room. She had a large blind spot in the left eye. She couldn't see any of the color plates, and she also had an afferent pupillary defect in the left eye, telling me she had optic nerve damage. And here's her MRI, and here we can see the optic nerve in the left eye is strongly enhancing with contrast. And if you note, it's almost the entire length of the optic nerve that is enhancing. We call that longitudinally extensive optic neuritis. And that's a tip-off to think about NMO when your neurologist sees that on the MRI scan. We can also see just a very bright, avid enhancement of the entire optic nerve in the left eye in these MRI scans. She was treated with steroids because we felt that this was pretty severe vision loss. And after 5 days of IV steroids, she really did not have any significant improvement in the vision loss. She still was only seeing count fingers vision. We then opted to treat her with something called plasmapheresis or plasma exchange, which required her to stay in the hospital for an additional week. 2 months later, her vision was still 20/20 in the right eye. However, the vision in the left eye only improved to 2400 vision. Again, that means that she was able to finally see that big E on the eye chart, but nothing smaller. So you can see here, in distinction to MS, patients with optic neuritis due to NMO frequently have severe vision loss that sometimes does not recover even with aggressive treatment with steroids or plasmapheresis. Her blood work did confirm the diagnosis of NMO when she had the positive aquaporin 4 antibody test come back. Not everybody with NMO has a positive test. It only comes back positive about 80% of the time, so sometimes patients have negative antibodies. A spinal tap was done and she had no illegal clonal bands, which is also typical in NMO. And 3 months later, we looked at that OCT scan, and if you remember our prior patient, she only had about 10 microns loss of her retinal nerve fiber layer, whereas in our patient, She lost 40 microns. She was 98 in the right eye and 58 in the left eye. This is just some studies reviewing the differences in OCT between patients with MS and NMO. And you can see with optic neuritis due to multiple sclerosis, patients' microns measure in the 70 to 88 range, whereas with NMO, the thinning is much worse in the 55 to 63 range, confirming that the damage to the optic nerves is more severe in optic neuritis due to NMO. This is just a picture of what an OCT scan looks like. So if you're looking at this, on the left side of the screen is the right eye, and on the right side of the screen is the left eye. On the top are the black and white pictures of the actual optic nerves within those green circles. And then on the bottom is just measurements looking at the actual thickness. And the left optic nerve is normal, so all those numbers are in the green there, highlighting normal, whereas the red areas around the optic nerve are highlighting the damaged thinning of the optic nerve in the right eye. This is a different patient I'm showing here because our patient had optic neuritis in the right eye. In the left eye, this is a patient with optic neuritis in the right eye. So a little bit more about NMO. So it can affect individuals of all races. The prevalence is about 1 to 10 per 100,000, and it seems to be similar worldwide. There have been higher reports reported of NMO in patients of African ancestry in the Caribbean and also in the Far East. It typically affects females to males 9 to 1 ratio, so it's much more common in females than males. If you think about multiple sclerosis, there's a slight preponderance of females to males, but it's only about 2 to 3 to 1 ratio, whereas in NMO, it's a much more female predominant disease, 9 to 1 ratio. Again, it's an autoimmune disorder associated with this aquaporin 4 antibody in the blood. And not only can it cause optic neuritis, but it can cause inflammation in the spinal cord, which is called transverse myelitis, or this area postrema syndrome. I kind of alluded to that earlier in my case when I talked about the nausea, vomiting, and hiccups. The area postrema is a part of the brain that controls your nausea. And so if you have any noxious stimuli to that part of the brain, that can induce nausea and vomiting. And for some reason, there's a lot of aquaporin 4 channels in that part of the brain. So if patients have NMO, they are at higher risk for developing this syndrome. So it seems that the prognosis in general for NMO is worse compared to MS, in particular with optic neuritis, but also with transverse myelitis. They tend not to have as good a recovery even with aggressive treatment. 41% of patients with aquaporin 4 positive NMO will be legally blind in at least one eye 5 years after disease onset. If you look at the visual prognosis from a Mayo Clinic study, at follow-up 8 years after disease onset, more than half of their patients were legally blind in one eye. But one thing to keep in mind is a lot of these studies were done before the era of treatments were available for this disease. It's a little bit different now, as I'll allude to later in the talk. There are now several approved medications for the treatment of NMO. However, they found that 15% of their patients, again, this is in a patient population looking from previously, were blind in both eyes. So can we prevent this from happening? The answer is yes, but we'll talk a little bit more about that later. I just wanted to highlight the transverse myelitis. I've been showing a lot of optic nerve MRIs. This is showing here really an extensive longitudinal inflammation of the spinal cord. And this is another tip-off that we're dealing with NMO. Typically in multiple sclerosis, a small single segment of the spinal cord is inflamed. So with NMO, we see at least 3 or longer segments of the spinal cord having inflammation, leading to weakness or paralysis of the arms and or legs. This can also lead to bladder dysfunction, unfortunately, too. 22% of patients with NMO may require a walker at 5 years. 8% may be wheelchair-bound by 5 years. And 50% of the time, the first attack in an NMO patient might be inflammation of the spinal cord or transverse myelitis. This is showing the MRI of somebody who has that area postrema syndrome. Again, they can present with intractable nausea, vomiting, or hiccups, not just lasting a few minutes, but typically several days in length. And no underlying cause can be found when you study the abdomen or if you have a colonoscopy or a CT scan of the chest, abdomen, or pelvis. Those will all be normal. Finally, we're going to talk about MOG disease. MOG is a more recently diagnosed or recognized entity. It stands for myelin oligodendrocyte oligoprotein. MOG is another protein in the central nervous system. It's found in the myelin, which again we alluded to is damaged in multiple sclerosis. However, we think now that patients with MS don't have the antibodies to MOG, whereas patients with MOG disease or MOGAD have these antibodies. Again, they can have inflammation in the optic nerve, the spinal cord, or the brain. And the symptoms can be recurrent optic neuritis, transverse myelitis, or another syndrome called ADEM, acute disseminated encephalomyelitis. So the immune system with MOG is targeting the myelin oligodendrocyte glycoprotein. It's found in the myelin, again in the central nervous system, and when this happens, symptoms arise that sometimes will get better with steroids. And in MOG, what's really interesting is that patients frequently will have bilateral optic neuritis. It might be coming on simultaneously where there's blindness in both eyes. Here's another case that we're going to look at of optic neuritis, but here due to MOG. We have a 38-year-old female who had left eye pain 3 days ago. She had foggy vision when she woke up, and it looked like she was looking through a dirty window. She actually had a similar episode in 2009 involving her right eye. At that point, when she had the optic neuritis, a year later she had transverse myelitis, and she was thought to have multiple sclerosis. She was therefore started on a disease therapy for MS called beta-seron, which she was injecting. And until this current attack, she had actually been doing quite well without any relapses. Her vision was down to 20/60 vision in the left eye. She had a little bit of color vision loss in the left eye, and she had that afferent pupillary defect, again confirming that she has optic nerve damage. Her visual fields were constricted in the left eye, and during the exam she was noticing that she had pain on eye movements, which is also a typical finding when patients have optic neuritis. And I'm showing here the pictures of her optic nerves when we look in the back of the eyes. So these are dilated fundus photos. The right eye, the optic nerve looks normal, but on the right side of the screen here, the optic nerve looks slightly swollen. It might be hard to see the difference, but the optic nerve is slightly swollen, which typically does not happen with optic neuritis. In most cases of optic neuritis, when we look back at the optic nerve, it looks normal. But with MOG, there seems to be a higher tendency for the optic nerve when we look at it to look swollen in the back of the eye. Here's a higher magnification photo showing that swelling of the left optic nerve again. And if we look at the MRI scan, again, we can see pretty significant enhancement of the left optic nerve on the MRI scan. And so the rest of the MRI looked normal, which I thought was a little odd because she had the diagnosis of MS. And typically with MS, we'll see lesions in the MRI. So we thought maybe we should check antibody testing. And we checked for aquaporin 4, that was negative, but the MOG antibody test came back positive. So we changed our diagnosis from MS to MOG, and we didn't think that the medication, the beta-seron, was appropriate anymore. Some other features of MOG optic neuritis. So MOG optic neuritis typically is recurrent. It can frequently be bilateral, and the swelling of the optic nerve known as disc edema can occur in 85% of cases. And there can be really extensive enhancement of the optic nerve, just like we see with NMO. Sometimes we're not 100% sure we can tell the difference between NMO and MOG when we look on the MRI scans, but there are some things that might tip us off. If we see the optic nerve sheath, the wrapping of the myelin around the optic nerve itself also enhancing, that could be a tip-off that it's MOG. If its optic nerves are swollen, as you can see here in both eyes, that's another clue that it might be MOG and not aquaporin 4 disease. And then if we see the more anterior aspect of the optic nerve enhancing, that's a tip-off that it might be MOG disease, where if it's more posterior near something called the chiasm, where the two optic nerves meet near the brain, that might be a tip-off that it's more NMO or aquaporin 4 disease. But there's always exceptions to the rules, so we still always have to check the blood work. This is just a table highlighting some of the differences between MOG disease and aquaporin 4. I'm not going to read it all, but I'm going to highlight a few things that I think stand out. One is that MOG disease is frequently more common in the pediatric population. These kids can sometimes have recurrent attacks of optic neuritis, transverse myelitis, or ADEM, I alluded to earlier, acute disseminated encephalomyelitis, where they can have confusion or delirium associated with large lesions on the MRI of the brain. As far as the gender predilection, again, aquaporin 4 disease, much more common in females, about a 9-to-1 ratio, whereas MOG disease, there's some evidence that it's actually equally affecting males and females. There can be bilateral optic nerve disease simultaneously with MOG disease, much more common there. It can happen with NMO, but it's less common. The recovery tends to be much worse with NMO. With MOG disease, patients tend to get much better with steroids, but one thing that we do know with MOG disease is sometimes when we stop the steroids, their disease will flare up again, and then we have to restart the steroids. So that's one tip-off that might make us think about MOG disease. And there's a part of the spinal cord that frequently is involved with MOG transverse myelitis called the conus, which is the very bottom of the spinal cord. That is not typically associated with MS or NMO disease, but is more frequently seen with MOG. You don't have to remember this. It's important for your neurologist to recognize all this, but I don't expect all of you to recognize all this. I'll just highlight here again some findings on the MRI and MOG optic neuritis. Again, here's another case where there's bilateral enhancement of the optic nerves. It's a little bit worse in the left optic nerve, but both nerves are showing enhancement. So again, if you're thinking about MOG disease, it affects men and women equally. They have very frequent risk of relapses, particularly in pediatric patients, of optic neuritis, ADEM, or transverse myelitis. I have to say though, because MOG is kind of a new disease, we don't even have official diagnostic criteria for it yet. We don't know the exact incidence and prevalence, but there's some suspicion amongst many MS specialists that there might be a significant minority of patients who have this were initially thought to have MS. So what do we do about this? Well, we have to do more testing. We have to study this disease more, and there are more trials going on to investigate this more, including studies to look at treatment options for this. So this is just highlighting again MS female to male ratio 2-1, so it's much more common to have males having MS. MS by far is still thought to be the most common central nervous system disease causing demyelination in young adults. There's about 1 million people in the United States with MS. There is no antibody associated with multiple sclerosis, though. So why is it important to know about these 3 different diseases? They have different prognosis. NMO by far has the worst prognosis. MOG seems to have a pretty good prognosis if we can control the disease, although there's a high risk of relapses. We know MS has variable prognosis depending on each individual, and it can be hard to predict the prognosis in general. So you have to really think about different presentations of MS. Patients with primary progressive MS may have a worse prognosis, whereas those with relapsing MS who start treatment early might have a better prognosis. Treatments for NMO. So we now have 3 FDA-approved treatments, which I'll talk about. But if patients have a relapse, we frequently will hospitalize them because we know NMO relapses can be quite severe. We'll do IV steroids early on, and if those don't work, we might next initiate treatment with plasmapheresis or PLEX. This is not something we typically use for multiple sclerosis, however. Typically, MS relapses will either not treat, or if we do treat, we'll treat with steroids alone. Patients with NMO also frequently will need physical therapy, occupational therapy, and if they have significant vision loss, possibly a referral to a low vision clinic. So prior to 2019, there were no FDA-approved medications for NMO-SD. Many patients have been treated off-label with a medication called rituximab, which is an IV infusion, and it's still used a lot today because many patients were already on that therapy. However, the first drug approved by the FDA for treating aquaporin 4 positive patients with NMO was eculizumab, which blocks a part of the immune system called complement. So it's only approved for adults right now, but we are investigating it actively in pediatric patients, and we might have the results of that trial in a year or so. This IV infusion has to be given every 2 weeks and takes about 35 minutes to infuse. Patients do have to get vaccinated before starting this therapy because it can increase the risk of something called meningococcal meningitis. 2 other medications that were approved last year by the FDA for aquaporin 4 positive NMO-SD were satralizumab and inebilizumab. These are also monoclonal antibodies. Satralizumab is a monoclonal antibody blocking interleukin-6 receptors, and it's actually something that a patient can self-inject at home once every 4 weeks. Because it's modulating the immune system, it can also increase the risk of infections. Inebilizumab is an IV infusion. Like rituximab, it's infused every 6 months. It blocks a slightly different part of the B cells, but it's similar to rituximab that it's blocking B cells. Again, it might increase the risk of infections. So when we think about treatment for NMO, once we recognize somebody has it, we need to start them on one of these therapies as soon as possible, whether it's rituximab or one of the 3 FDA-approved therapies I already mentioned. Once somebody has aquaporin 4 disease, NMO, they're at very high risk for relapses and disability and morbidity. And so the name of the game is prevention of relapses with NMO-SD. We don't want patients going blind, becoming wheelchair bound, or in very rare cases, dying from the complications of their attacks. So once we diagnose somebody with NMO, we get them on treatment as soon as possible. If you're antibody negative and you have NMO, we don't have approved therapies by the FDA yet, but there are therapies that we can still use that suppress the immune system. Also for MOG disease, again, there are unfortunately no FDA-approved therapies yet, but there are clinical trials that are going to be starting soon to look into therapies that might work. One of these is going to be investigating satralizumab to see if that might help prevent relapses in patients with MOG disease. Sometimes we treat patients with MOG disease with other medications like rituximab, mycophenolate, or azathioprine. So in closing, if you have NMO or you want to find out more information, or if you have MOG disease, or even if you don't have these diseases, you want to learn more, there are patient support groups, the Guthrie Jackson Foundation. You can go to their website listed here, and also the Samara Foundation have great resources on them that will fill you in on more information both about NMO and MOG. Thank you again very much for your attention, and it was a pleasure seeing you all today.